Our next talk then is from Peter Kas. Yesterday we started to speak about this. Things that we've been doing for many years without questioning them, fasts, log rolls, PR exams. Pete's going to tell us about, should we still be using them? Are they useful? Is there a role for them? Thanks, Pete.
All right, so potassium is the devil's electrolyte and ketamine is God's gift to the emergency physician. I'll keep pushing that line. All right, I wrote this a little while ago and I did a blog on it, and it created quite a lot of controversy because it challenges a lot of what we believe in. And I sort of related the talk, we bumped the talk a little bit, but I wanted to relate more to Gerben's talk. He's going to talk about deliberate clinical inertia, where sometimes we just, maybe things don't add what we think they add and maybe we should get rid of them. But when I wrote this, I had a response from the team leaders in the Canadian trauma centres, and we had these, discussions by email and everything. The outcry was significant. So let's just have a little bit of think about what we do and why we do it. So here's the case. You get called ETA, 15 minutes, 25-year-old male, high-speed motor vehicle accident. He's hit a barrier, his vitals are normal, GCS is 15. He's had a loss of consciousness though at the scene. He's got a scalp black, left-sided chest wall pain, and he's probably got a closed tibial fracture. Okay. So, depending on where you are, you might do a trauma alert. You might, jump the gun depending on whether you've got the mechanism is significant enough. You do a trauma call. If you're in a rural centre, you do a trauma cry for help. You might not have much at your disposal. But, in this particular case, you call the surgical registrar to give you assistance in our little trauma centre, and comes down, and the anaesthetist comes down to give us a hand, and the trauma registrar is a little bit junior, but he's come down, or his surgical registrar is going to help us. We thank him very much for that. Comes down, assesses, looks at the patient's ears is the first thing he does, says ears are clear. I'm pretty happy with that. So I say, well, that's fine. Let's just send him to the ward. It's all good. But then you say, look, can you just do a proper primary survey for me? Okay, let's just do primary survey. The patient's pretty stable. Let's just do a primary. And he's really good. He said, the vitals are really good. Airway's intact. Breath sounds bilateral. He's got rib pain on the left-hand side. And the rib pain is going sort of up and under at his abdomen as well. I'm a little bit concerned about it. The pelvis is normal. Probably got a lower limb fracture, and that's well treated at the moment. Fantastic. All right. So I say, we're pretty happy. And then he kind of keeps yodeling on about something, and I kind of lose interest after that. Yada, 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 yada. I'm thinking to myself, what am I going to do next? Let's get the CT. Let's do it. What are the chances that this guy's going to get a pan scan? Who thinks 100%? I think 110% he's going to get a pan scan, right? So the pan scan is the salvage of the rural emergency department, is my view. Okay, so we do these things. But then all of a sudden the surgical registrar says, hang on a minute, he's not going anywhere until I do a log roll. Why? Why are you doing a log roll? Well, we've got to look for other injuries, penetrating injuries. We've got to assess the spinal column, and we have to do the most important exam of all, the rectal examination, the punitive examination of the surgical team. Right? We have to do this. Now, recently, when I said, I don't think we need to do this, the outcry was, well, hang on a minute, there could be a penetrating injury we're not seeing. I said, so you mean somebody stabbed him in the back before he had the crash? I said, no, it could be a shard of glass from the windscreen. I said, windscreens don't break in shards, they break in little pieces. Well, there could be something in the back. Now, there's something to be said about total examination. But there's something to also be said about what is that examination going to pick and give us that we're not going to get from the pan scan? Very little, I think. Let's have a little look. If it's a penetrating injury, sure. You've been stabbed in the front, you might be stabbed in the back. Is it going to add anything? Probably not. And if there's a knife still in there, don't remove the knife. Leave it in there. You don't know what's going to happen when it comes out. If it's not a penetrating injury, I don't think it's going to help me a lot. I'm not sure. This is controversial, but I don't think it's going to help me a lot. So why are you going to do it? I must assess the spine. So when you examine the spine, if you think the spine is okay, that's all right, isn't it? Or if you think there's an abnormality, what am I going to do that I wasn't going to do, like the reconstructed spinal views? And these are the questions we need to ask. And so when we look at the literature, the log roll causes significant spinal movement. The log roll can cause disruption of clots in the abdomen. The log roll can have significant effects. Now, it causes a lateral movement rather than rotational movement, and that movement it's been tested in cadaver models and other models, that movement is related to body habitus. Okay? My bigger belly is going to cause me to have lateral movement of my spine. And the problem is that it tends to cause the greatest amount of movement at the thoracolumbar joint, and it may in fact cause the greatest amount of movement in that bit of the spine that's broken that you don't want to move. So the log roll is not necessarily the panacea of spinal immobilization. All right, what about palpating the spine? What does that tell us? In the conscious patient, GCS of 15, no neurology and not intoxicated, it's actually shown to be not too bad in predicting whether there's a lumbar fracture, but it cannot exclude thoracic fractures. In the unconscious patient, it's rubbish. Why are we doing it? I'm feeling for a boggy mass. Well done. Doesn't give us anything. And then, of course, there's my pet hate. This exam. Okay? And I say to the... you'll give me the ball next time, I tell you. So I say to the surgical registrar, why are we doing a rectal exam? And remember the old days, there are only two reasons for not doing a rectal exam. No finger, no anus. Only two reasons to not do a rectal exam. But the reality of it is, we really don't know what the hell we're looking for. And the studies are retrospective studies, but the studies are showing you can't predict spinal cord injury. You can't predict bowel injury. You can't predict pelvic injury. You can't predict rectal injury. You can't predict urethral disruption. You basically can't predict diddly from the rectal exam. So why are we doing it? It's what we're used to doing, and we think it's complete. But I can tell you, in a blunt trauma patient, when we're doing a pan scan, I don't think it's going to add much. And it's certainly not going to change my immediate management. Right there and then, if I find something in the rectal exam, it's not going to change my management. So CT call and say, we're ready for the patient. No, I have to do a fast scan, and Hansel's here, the echo guru. I must do a fast scan. And I say, what does the fast scan add? In the hemodynamically stable blunt trauma patient, what does the fast scan add? What we're looking for is a hemoperitoneum. We're looking for blood in the peritoneal cavity or blood around the heart. That's what we're looking for in a fast scan. And in the hemodynamically stable patient, it might have a second triage role. It doesn't add much. In the unstable patient, if you've got blood in the peritoneal cavity, unstable patient, it should lead to the operating theatre. We know the reality of that is that that doesn't always happen. Some of those patients are a bit unstable, they've got blood in the cavity, and they still go to CT. And I talked about the literature on that a couple of years ago at EMCOR. So I'm not sure that the fast adds a huge amount. I'm not sure how much it helps me if I'm doing a pan scan. So benefits of it though, it's rapid, non-invasive, we can repeat it as many times as we want to. It can diagnose those things, but does it help us? Does it change my management? Does it make me feel better? Maybe. It makes me feel more anxious if I can't see those kidneys properly, if I can't get a good view of Morrison's pouch, if I feel a bit inadequate in my technique. What are the limitations of the fast? Well, certainly it's good for detecting that blood, 400 mil, 600 mil, whatever it is. But it's not very good for solid organ injury, and we can't rely on it. Now, certainly maybe in kids, and Claire will talk about this a little bit, sometimes serial examination is the best way to go in some of these kids. You're not going to do, you're not going to get in and treat. And serial examination has actually been shown to be pretty good in adult trauma as well. But I don't know that the FAST is going to add anything. Well, what about the EFAST? The EFAST lets us look at the chest and see if there's a pneumothorax or a hemothorax. And we've listened to a little bit about spontaneous pneumothoraces yesterday. We looked at occult pneumothoraces this morning. How good is the EFAST at picking up pneumothoraces? The literature says it's about twice as good. The reality is we pick up as a chest X-ray. So we pick up about 87%, 80-something percent in a FAST, and we pick up about 20-odd% in a chest X-ray. And here's my question to you. If we're picking up more, the ones we didn't see in the plain X-ray, and it actually concurs with CTs, we've just heard from Will that maybe we shouldn't be treating those. Are we now going to be potentially treating things that we wouldn't have treated before on a plain X-ray? Will it change our management given that this patient's going to have a pan scan and we're going to see that pneumothorax on the pan scan? So this stuff is controversial, but it's stuff to think about. And it's your personal decision. And I know I start to feel uneasy when everybody looks at me very strangely when I say, let's not do the log roll, let's just go to CT. I need to do a FAST. Don't worry about the FAST, let's just go to CT. Patient stable, blunt trauma, I'm pretty relaxed. And I feel uneasy about it. And we're used to doing full examinations on patients. Exposure, exposure, exposure. But maybe these things don't add anything. Certainly I don't think the rectal does. Log roll, I think, is almost useless. We can't pick up spinal injuries. We can, in fact, dislodge clots. We can make spinal injuries worse, as shown by the literature. Spinal palpation, I don't think, gives us diddly, especially if we're doing reconstruction views on the CTs we've already done. That doesn't add any extra radiation. And rectal examination, I'm not sure what it does. And like that cartoon, I most of the time have no idea what I'm looking for. So this is a bit of a challenge to the dogma and something for you to think about in your patient, in the blunt, hemodynamically stable trauma patient who's going to get a CAT scan. Thank you very much.